My name is Ulrike Stolber. I'm part of the team in the Clinic Landstraße since, well, for me it's more than 25 years. I'm coming from the vitreoretinal surgery corner, and I installed in this clinic a special department for diabetics, coming from the surgical side, but now we are going on, of course, with medical retina as well. So, biomarkers. I told here in the front row, I told the ladies, this is nothing scientific right now. I'm talking about what we are doing every week and what we have learned about OCTs, what we have learned about to connect it with therapies and how useful it could be or not. My first question to you is, who sees diabetic patients regularly? All of you. You see it every day? Or who sees them every day? Who would like to change with them? No one. Okay, every day that's pretty hard, but you get a lot of experience when you see them every day. So, this is my picture gallery. A mixture of diabetic edemas all around, higher, lower, bigger, smaller, fluids here and fluids there, dots here and there. So what we have learned, they are not all the same, and probably they need a different approach. And what we see in details, I will show you now, because this is not all the same. There are so different aspects here and there, which we can go through. And what I say, you just see it when you know it. When you don't know it, you will oversee it. And there are some important informations because they give you an idea how a therapy could work or how long a therapy has to run, or if you have to change the therapy. What are biomarkers? They mark bio, the life. So biomarkers in diabetics are various because a biomarker is the duration of the diabetic disease as well. It's the HbA1c level, that's the hypertension or not. So these are all biomarkers, but we'll concentrate on the biomarkers on OCT. And we have some familiar names here. When you look at the VEGF, interleukins, so all we have known and heard about, but they are connected to something. They are connected, associated to these features here. Subretinal fluid onset, for example, interleukins. So when they are high, they lead to a subretinal fluid accumulation. Or this VEGF, when this is high, it will lead to microglia activation. So what is this? Do we see this or not? And what is this? We'll see, yes, we can see it. So, from the beginning, we started with these pictures. So we got some information from here. Let's say very basic information, but we were glad to have this one instead of nothing. And we learned to measure the central thickness of the retina. We learned that there could be fluid here and there are some cysts, but not more. And during these phases, we learned that a high edema is worse than a low edema, that the reflection, a low reflection is worse than a high reflection, and these things, but this is not enough. When you look here, we see nearly all the layers, nearly even single cells. Let's say if we see this here is a single Müller cell, looks like a column here, so there's not so much left. But it doesn't depend only how much is left here. It depends on different things. So all these parameters here are biomarkers. Yeah? Everything. From the vitreoretinal relationship up to the single layers of the retina, you see these are all biomarkers in a diabetic edema. These three first ones are the ones we have seen in the first OCTs, in the old OCTs as well. Does someone have still an OCT as I have shown at the beginning? This yellow, red, green ones? Yeah? In OCT. No, this old one. This one. But the new one as well. So everyone is familiar with this picture, I suppose. Yeah? Good. Okay. These three parameters are seen in an old OCT as well, because it's seen on the first side, the reflection, the height, so this is not so difficult. But when you go into details, you have to differentiate where fluid is, how fluid looks like, the different layers from outside to inside, and some special things like hyperreflective foci. I think for those who have had Latin in school, foci is terrible. It doesn't, we do not spell it foci. That's the Anglo-American pronunciation. In reality, Latin, an old Roman would say, my goodness, this is foci and not foci. But we will say foci because this is understood everywhere. So, biomarkers. We start with the vitreoretinal relationship. If you look here, that's a classical, let's say, splitting of the posterior hyaloid. Usually it's not a detachment of the posterior hyaloid, that's splitting, connected here. Maybe it plays a role in creating this edema or sustaining this edema. It's not, usually it's straight and not curved. This makes the OCT machine, and it's usually straight from here to here and makes a bridge. If you see this, and it increases, you can consider that a treatment with anti-VEGFs, for example, can't be too successful, because when there's enough traction in it, you can inject and inject and inject what you want. It doesn't release from here. This one, for example, this won't work with anti-VEGF therapy. This works with vitreoretinal surgery, membrane peeling from here. This is the postoperative picture. But when you look carefully, it won't be too good from the vision. The surface of the retina looks good, but look here. Not too good, but better than before. When you measure the thickness, the machine does everything. Shows you in 2D pictures how high it is, looks like a volcano. And when it's flat, it's more blue and green. The red one means it's going up. And it gives you numbers. So you don't have to measure it, it gives you the numbers. This is quite high, let's say twice as high as it should be. And it's going to normal ranges here in the periphery. So a classical edema right in the middle. Easy. But it does not depend on the height of the edema itself. When you correlate this height of the measurement of the height and the visual acuity, it's logical that this one has a better vision than this one has a better vision. This one, you see, there's nothing on, there's no layers at all, but here is just a little cyst. Probably not only a cyst, could be a pseudocyst as well, but it looks quite fine, and we see that the visual acuity is very good when the center is normal, and it's going down, 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 the higher the center in the macula is. When you measure it more than 600 microns, it can't be the same as in the comparison to a normal macular thickness. So if you look at the reflectivity, that's what we could do with the first pictures as well. You see, this is a low reflectivity, and this is a much higher reflectivity, which is also logical, because when the edema goes higher and higher, the reflectivity goes down and down, and therefore this has to be worse than this one here in the upper picture. Yeah? But it's not only these parameters. When you look here, you see much, much, much more than just the height of the center. So we're going into details. We look at fluid accumulations. Here you see various fluid accumulations here. There's little ones, the big ones. They're round, they're flat. Even here we have to look. So we find different categories. The cysts here. The diffuse accumulations here. And the subretinal fluid here. So these three categories are very important, because they have a different, let's say, influence on the treatment. When we measure the central retinal thickness, compare it to the, let's say, average visual acuity and to an ERG, we see that in subretinal fluid cases, of course, because it's right in the center, the central retinal thickness is going up and it's the highest because this is in the middle. Fluid here, diffuse fluid accumulation is not in the middle, so it has not such an impact on the central retinal thickness. Here is the highest, and when it's here right in the middle, the average visual acuity is the worst here, of course, because the middle is affected. And the retinal sensitivity is the worst because it's in the middle, so here nothing is working anymore. The diffuse accumulations are outside, left and right, so the central retinal thickness in average is better than compared to the subretinal fluid, and the sensitivity as well, and the visual acuity as well. So it makes a difference where the fluid is and how it looks like. Yeah. So, for example, a clinical example, the subretinal fluid responds very well to anti-VEGF therapy. When you look here, injection, 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 fluid is less. Here, a bridge in the middle, and here it's gone, completely gone. So the surface of the retina is quite good, but the visual acuity is a different thing. When we look at cysts, we see much more than cysts. They are usually in the inner nuclear layer and the outer plexiform layer. These are the bipolar cells. The nucleus from these bipolar cells are seen here in this dark area, and the connection to the photoreceptors are the outer plexiform layer here. So here you find most of the cysts. Cysts look different. This is a cyst with a low reflectivity, so nothing is in. A cyst with high reflectivity, and when you look at it, you see these little spots all around, which we don't find here, but we find them here. And they are heterogeneous cysts. They have both some high reflective areas and some low reflective areas. And the dots are not so common compared with this stage here. So when we stain it, we have a different pictures, a different pooling. In a low reflecting cyst here, I have to push it better. In this low,
Based upon you may be covering it with your finger.
I need a bigger hand. My hand is too small. I cover it, yes, you're right. I cover it, thank you. So when we stain it with fluorescein, you will see a low reflective cyst, there is enough space. So everything can run in, and you see a marked pooling here and there. When there's, let's say it's full with material, nothing can penetrate, or it penetrates very slow or slowly or lower. So it's a moderate pooling here. And you need breakdown of the blood-retinal barrier, because otherwise this material wouldn't be able to penetrate. Yeah, though this is a more advanced stage of a cystic edema than this would be. So the prognosis of this one here is worse in comparison to this one here, because this is an early cyst and this is a late cyst. And we see these little spots here, which we cannot find here. Very characteristic. When we stain subretinal fluid, nothing changes. So you don't see it on the angiogram, it's just seen in the OCT here. And when you look here, this doesn't look good. It looked like a tear or something here. See the cells pulled up. But when you see a hole in the OCT, it's not always a cyst. It can be a hole. So when you compare this cyst, which is not a cyst, and this cyst, and these spaces here, they are all different. Not necessarily have to be treated with anti-VEGF, because this macroaneurysm, which is leaking, probably won't respond. The cyst will respond, but this tiny, let's say, empty cysts are no real cysts, they're just empty, so there's no tissue here, but it's not a cyst. A cyst is a cyst has a wall around, and then inflammatory exudate inside. But this one has nothing, it's just empty. So when you see these holes here, think about pseudocysts, because that could be a pseudocyst as well. So when a cystoid macular edema is healing, there could be some places left where no where no cells are present. So then you get these pseudo holes, like this one here. This is a macroaneurysm, so it's not a cyst, it's leaking here. These are hard exudates with diffuse edema here. So not necessary to treat all of them. And we did it, an example here, in this patient who had cystoid edema, or we thought it's cystoid edema, and he got the treatment, and IVOMs, and IVOMs. IVOM mean intravitreal operative medical injection. Here's a microaneurysm here, and we injected, and then we did nothing. We just saw this little traction here, and had this, let's say, hole here. And as the visual acuity did not change, we didn't do anything, just observed him. And observed him for years and years and years. It became a little bigger, but the vision was stable and is still the same. And since 10 years, he has 0.8, so not necessary to treat forever and ever and ever. This is not a cyst anymore. It's not an inflammatory reaction. It's just a hole. There's no tissue here, and this is nothing to treat. Yeah, so you have to be careful. And if you see cysts and you're not sure, you can stop your intravitreal injections as well and just watch and observe what happens. And we have learned nothing happens, or there are some cases where nothing happens. We go more and more into details, so we look at this outer retinal layers here. We're talking about of this thin line and this more white line. Whoop, keep it here. These outer segments, which is very, very important. We learned that it's more or less decisive if you get a good vision or not. These lines are the end of the Müller cells here, the ELM, and the connection from the outer segment to the inner segment of the photoreceptor cells. And when you look here, you see this line here, the thin one and the thicker one here interrupted or going up. There's tissue under these layers, has an impact on the visual acuity, of course. But what does it tell us? It tells us a lot. So, see it here, thin line, thicker line, the ELM and the ellipsoids. Yeah? And we have the cost here, the cone outer segment tips. And we're talking now about these three lines and what we learned and what we see. We are here, the end of the Müller cells here, the ellipsoids, the connection from inner segment to outer segment, and the cone, this is a cone, outer segment tips here. And they have a different impact. Some are more important, some are less important. You have to imagine the ELM, let's say, yes, so the end of the Müller cells. This is like a root of a bush, a tree, or whatever. So this is the important layer. Yeah? The ellipsoids, that's what's growing from this one here. So when you look at these pictures here, it's possible that you have both lines, ellipsoids and ELM. You can miss the outer segments here, the ellipsoids, but the ELM is intact. You can miss both from here to here, nothing. But it's not possible that you have no ELM and then ellipsoid. Yeah? This is, the roots here are important to restore this one here. So when you look carefully at the OCTs, you might find all these three stages, but we can also stain it. With an OCT, you can, I do not do it regularly, it's just from a scientific paper. The contrast can be enhanced. This is a normal eye. This is a typical cystoid edema. You see there's nothing in. And when you segment it, these enhanced lines, you see there's so much missing already. This is a normal eye in comparison to a cystoid edema where all the ILM is missing here. So this can't work in the same way as this one works. Huh? When we compare all these three lines, the ELM, the ellipsoids, and the COS, the cone outer segment tips, you will see that the ELM is the most important layer. Yeah? See, when it's complete and disrupted or absent, that's a logarithmic visual acuity. When it's absent, the visual acuity is worse. So logarithmic means this is good, this is worse. And it's completely present. It's much better than in comparison to disrupted, and much better in comparison to absent. And when we put a line here from absent, you see that this is has the most important impact, the ELM. The cost doesn't play such a major role, but the ELM does. Yeah. It's the highest significance of all three lines. When the ELM is not present, it doesn't work anymore. We see this in some examples. These are anti-VEGF eyes with a subretinal fluid. Both lines are here. You inject it, it's dry now, the visual acuity is excellent. In this eye, we have just the ELM and not the ellipsoids. It's interrupted here, from here to here. The vision is a bit worse, and when it's treated, the vision goes up, but not in the same extent as here. Yeah? When both lines are missing from here to here, you can inject what you want. It will get dry, but the visual acuity didn't nearly change because these outer lines are not here, and they do not restore. This might restore when the ELM is here, but this cannot restore anymore. So the vision is somehow better, but not satisfying. After vitrectomy, you see the same. Retraction, edema, cysts, spots, both lines are here. After surgery, both lines are here. The vision is excellent. Another edema with a thick membrane, which we peeled. There's nothing from the outer lines to see, just here a bit, and it's not going on the other side in this picture. So even if the surface looks nice, it doesn't help. So this is nearly the same in the visual acuity. So it's important to look at it before you start doing anything, because it's important to inform the patient how the outcome could be or not, what he could expect, because this picture helps a bit, but it's not to compare with this picture here and that's on the other side. So cysts have a different extent, and we categorize it from type 1 to type 4. This means type 1 is less than 1/3 of the central retinal thickness. This means completely central retinal thickness is a complete cyst. And it's logical that this can't work in the same way like a small cyst, because in these small cysts, the lines are usually present, but both lines, the complete outer segments, are missing in these lines. So it's more or less a 100% correlation. And this is the reason, not because it's so high. The reason is that these lines, these cells are missing, and even if it's working and the therapy is working, the outcome is not the same compared to these eyes here. So there's a category from 1 to 4, and from good chance to small chance of improvement. So we're going more into detail what I told you at the beginning, to look at this hyperreflective fossa, because they made such a big input on scientific reports, because no one looked at it. But they're important because they show you in which stage the edema is and how intensive the treatment has to be. If the same picture is here, you see not so many. Okay, but as you've seen this VEGF factor with the microglia activation. Microglia can circulate or can be local. And where are they? What is this microglia? Microglia is this one here. This spiders, let's say, they are everywhere. They connect cells here and here and here. So they are sleeping, let's say. They are active, but just working and not hyperactive. And when they are activated and not resting, they become bigger and bigger and bigger and round. Yeah, they're connecting these cells and they're becoming round and bigger. And this is what we see here in all these spots. Probably they are loaded with macrophages because they are so dark here and very intense. So this is the same, it cannot be the same as an eye without with hyperreflective foci. You see this is missing from here to here, a lot of subretinal fluid. And these hyperreflective foci, these activated microglia, you find everywhere, from the inner up to the outer layers, everywhere. They are all migrating within the retina. Not to compare with hard exudates. This is a typical hard exudate with an OCT. You see, it makes a little mountain. But this is a different thing. Here you see no hard exudate, but you see all these spots here, 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 here. And a hyperreflective cyst with the spots inside. So a more pronounced edema, which we see here. And you see them even in the deepest layers, you find these hyperreflective foci. They are falling down, let's say. We categorize them about, this is a few, you see here and there. These are more, it's moderate, here, here, here. And there are many. And in all layers you find them, in the inner as well as in the outer layers. Yeah. See this combined cyst, hyperreflective and low reflective cyst. Very typical. So there was a lot of discussion. What is it? It looks different here. You see these hard exudates, they make a shade, but these hyperreflective foci don't make shades here. Are they the same? No, they are not. Associated with high reflective cysts, yes. And it's a more advanced stage of an edema because you need a breakdown of the blood retinal barrier. Otherwise, these diffusions would not work. They are proteins or lipids, or both, probably macrophages. So it means that it's an inflammatory reaction. All these many, many spots are inflammatory and probably need more than anti-VEGF. Actually, it's not clear when to start with steroids. There's not a single paper, I didn't find one, which says definitely when to start with steroids instead of or in combination with anti-VEGF. But probably eyes need steroids in these cases. They are additionally in the inner layers, in the outer layers, which I've seen. And as the more they are in the outer layers, the more the ellipsoids and the ELM is disrupted. But they can be reversed by anti-VEGFs. You see less works very well. Many HFs, and it doesn't work so well. So there's a correlation between the number of HFs and the number of anti-VEGF injections. Here we'll need much more than here. And you see there's the same central thickness here and there, the same cysts, but it's definitely a difference between this one and this one here. It's correlated with a high HB1AC, of course, because it means that there's more intense phases of the phase from the diabetic disease. So, good. Next one, we don't have only outer layers, we also have inner layers. They were not so respected in the last, before 5 years before, but they're more and more respected because it says a lot, of course, because all together is working or not. And we have the same picture here and see, oops, where are these layers? We're talking about this one here, the inner plexiform, inner nuclear layer, which we see this big, or this first dark line in the middle, that's just the nuclear layer, and the ganglion cell layer, nerve fiber layer. And when we look here, we are here, the nuclei from the bipolar cells and the connection to the photoreceptor cells. And we look here, it's dark, light, dark, light, dark. For those who are hungry, who knows this cake? It's a Schwarzwälder Kirschkeke. But it's so comparable because we have dark, light, dark, light, dark. These nuclear layers and the plexiform layers. That's a cream in between. Yeah? And we have to differentiate these lines here. So if you eat the cake, you can eat it layer by layer. These are the hyperreflective foci. Or a hyperreflective cyst. Okay. When we put lines here in our OCT, and this is 1,000 microns, so this is not so much, and we don't do it with our regular investigations or examinations, we just look at it. But if you do it line by line, you will see here it's working dark, light, dark, and here is something is in between. This is an example, 1 millimeter from the middle, left side, you see it on the first side. This cannot be the same like this one here. So here is no layer anymore, and here are the layers. Yeah? You can make the lines here from dark in the middle. This is easy to remember. And on both sides you see that slide, and here's nothing. So this is completely destroyed. And it has an impact, because when you see that more than half of this millimeter is affected, then the visual acuity is affected, which is clear because half of this millimeter is in the middle, it's in the foveola, therefore the visual acuity has to be affected. But when you compare it and increases during 4 months, it's more and more and more, then you can expect a visual loss of 1 line after 8 months. So this shows you, or that gives you an idea how visual acuity will develop. So if this goes on and on, it's destroyed, even if it's dry and no fluid in, if this one goes on, the visual acuity will go down after several months. But if it decreases, so it restores because it's getting dry, then you will see there's no change in the visual acuity loss. It doesn't mean necessarily that the visual acuity is improving, but it means that it doesn't change, which is also important, not to lose vision, to keep it as it is. So this is probably a very important biomarker where you can read the future. So when we look at all these things, where do we look at first? Here. Is there a membrane attraction or not? Then we look or see on the outprint or on the screen how high it is. You look, where is fluid? Diffuse, subretinal, or cystic? You look how the cysts look like, how reflective they are. If there is space and a microaneurysm and not a cyst, a leaking microaneurysm here, very typical one here. Then we look at these lines, outer lines, nearly missing, you don't see it very well, but probably missing from here to here. Yeah. Is there an integrity or not, an interruption? We look at these HFs. So these are about 5 to 6 steps, which are very simple. When you see this picture here in front of you, drill a disorder of retinal interlayers. Here, not. Here, yes. And we look if there's subretinal fluid. And that's pretty all. Not more to do. So when we see this, we start with anti-VEGF therapy. This is the standard therapy. We have a strategy, let's say, give 3 injections. Usually we have Eylea. Give 3 injections in distance of 4 to 6 weeks. 6 weeks is also possible. So we have a loading phase. If this is over and it's, let's say, better, we're going on with longer interruptions. So we make, what do I want to say now? We make treat and extend, that's what I was looking for. Treat and extend. So if it's stable, we extend the interval from 4 to 6 weeks, from 6 to 8 weeks. If it's the same, we go on with a 3 injection series, a second one. And if nothing changes, then we add steroids, not before. And this is just a personal feeling, that nothing to do with a scientific result, let's say. This is just what we think and what the most of the clinics do, add steroids and hope that it's going better. If this is not working, we enlarging the treatment intervals to 6 weeks, and then we give 1 to 2 and make just an examination at the second injections to avoid so many visits from the patients, because you can adhere them. The more visits they have, the less they like to come. And for me, it's, yeah?
IV steroids?
Yes, IV with Ozurdex, for example, or Trisense, or triamcinolone, whatever you have. All of them are working. So we enlarge them. For me, this is my personal experience, that people are adherent more than when they know that they have an examination every 2 or 3 months and they get an injection. This is fixed. Because when they have to come very often, every month, and nothing happens, you will hear sooner or later, I was there in vain. Nothing changes and nothing improves and nothing is done. So this is very difficult. So psychological, it's easier to give them a date, an examination date where they get a fixed injection or not, whatever you plan. But treat and extend is for me more handleable than Pro-Renata, because they need a lot of visits and we don't have the capacity to do so many follow-ups. What we also have learned was that anti-VEGFs are good for a variety of diabetic complications. And the question is, when we inject it, what is the positive side effect on the diabetic retinopathy? So, could we use them for something else than a diabetic edema? For those who like diabetic papers, the DRCR network is perfect. The diabetic retinopathy clinical reports. These are big protocols, usually more than hundreds of patients are included all around America or all around the world. And they have, starting from simple laser treatments up to very sophisticated questions. For example, if an edema with a visual acuity of 0.1 has to be treated or not. So this is, some of them are running, many of them are already closed. And this one here was very important. That protocol I was intravitreal injections for diabetic edema. But it had a side effect, because they saw that also the diabetic retinopathy changes. When you do a series of intravitreal injections, you see that the probability that the retinopathy is worsening is much higher in these patients where there was all simple and sham injection and a laser from the edema, in comparison to those patients who got anti-VEGFs. So this was the side effect which was observed and led to another protocol, the protocol S. In this protocol I, it was very interesting because you have to read it carefully. They had moderate retinopathies, very or severe retinopathies, and proliferative. And under this anti-VEGF therapy, it improved a bit, especially the proliferatives, but this effect was going down. After 3 years, it was less than after 1 year, and after 5 years, it was much more less than at the beginning. So it worked, but it didn't work continuously. It was better in the moderate cases, because this improved a bit from study end to study end. And the very severe ones were about the same all over this time. So let's say 4 out of 10 patients had an improvement from the diabetic retinopathy under anti-VEGF therapy, but 6 of them did not have. So this is a bit, have to be seen very critical, especially in these cases, because it's very popular to inject anti-VEGFs instead of doing laser therapy in PDR cases. But you have to know, we'll go down and we'll see it later, that it does not work so very well. We need a lot of injections. So in these years, a summary of 12 to 14 injections, which have to be bared even after 5 years. They need injections probably every 3 months. And imagine that you go in a clinic 5 years and you get even injections. Could be critical. The protocol S compared the prompt laser treatment in comparison to anti-VEGF and laser treatment afterward if it's necessary. This was a typical picture at the baseline from the protocol S, injected, 8 days later, poof, it's gone, nearly disappeared. 8 months later, they stopped injecting. It looked completely the same as at the beginning. So, has to be looked at carefully. So the study design included a lot of patients with PDR, not severe and not moderated, only with PDR. And eyes were included with a central involved DME or not. So both categories were included. The aim of this study was to show that intravitreal anti-VEGF therapy is not worse than laser treatment. Yeah? So concerning the outcome of the visual acuity. But the secondary question was, are there any other effects? For example, the changement of the vision, but also the visual field in the periphery, and how the macular edema reacts, or if a macular edema increases if there is no anti-VEGF done. And how is the side effect? How many vitrectomies are needed in both groups? And we look here, after 2 years, the visual acuity didn't change so very much. 3 letters, this is nothing. In both groups it was going up here in the anti-VEGF group, and it was rather stable here in the PRP group. So no difference. But when you split these group into patients who had a baseline DME and those who had no baseline DME, there was the effect much better, of course, because with the anti-VEGF therapy you treated not only the retinopathy but also the DME, and therefore the visual acuity is going up much more than in the PRP group. There's no difference, that's what we have seen here, a bit of improvement, but after 2 years there's nearly the same in both groups. So it works instead of laser treatment when you have a baseline DME. So when you look at the 2 years 2 years aspect of the retina, we see that in both groups about 1/3 has no PDR anymore. Yeah. So this is quite good. Here in 1 quarter it's regressed, but a lot of them have still active INVs. So you have to keep them under control, because active means active, can go on as well as can start bleeding, can make infection detachment. So this is quite high for me. So no statistical significance, we can do both. But when you look at the side effects here, the visual field, of course, in the laser group is going down, much more than here, which is not as a very big surprise. And what I found interesting, that here there are much more vitrectomies in the laser group than in the anti-VEGF group. Oops. Here. Yeah, compared to here. All the other parameters are the same. Nearly the same number of retinal detachment, neovascular glaucomas in both groups, neovascularization on the iris in both groups, and vitreous hemorrhage a bit more here. But the vitrectomy group is much higher in the laser group. Interesting for me. So, no surprise that the laser group developed much more diabetic edemas during this follow-up of 2 years in comparison to the anti-VEGF group, because this prohibited more or less the edema. This did nothing on the edema. So the protocol said after 2 years, Laser is good, needs fewer visits, no injections or fewer injections, and it's very cheap. And when you don't have an edema, it makes sense just to do laser treatment. In the anti-VEGF group, we saw that it's not inferior. You have less peripheral visual field defects, a threefold decrease in vitrectomies. This is interesting for me. A decreased number of developing edemas, and it's more expensive. But it makes sense when you have both PDR and edema to inject it, because then you get two treatments in one step. But 2 years are not so much. So we have to look on. 2 years are nothing in the course of the diabetic life. 5-year outcome was following. And we see here, after 5 years, both groups the same. Nothing, not a single difference. So this difference disappears over the time. And we look here. This was interesting. The number of injections, while injecting over 5 years means a lot of visits and a lot of injections. And you see that the number of non-injections needed anymore, and they were treated PRN, no injections. This is always becoming more and more. After 2 years, 3 years, 4 years, and 5 years. 37% don't need any injections anymore. Yeah? This is quite good. But on the other hand, when we look here, after 5 years, the number of 4 up to more than 10 injections, this is pretty high. This is more than 40%, 43%. This 4 out of 10s need 4 to more than 10 injections. This means monthly injections after 5 years. Who would like to get it? If you feel as a patient? No, not for me. They didn't include vitrectomies because I'm coming from the surgical side, so I'm read these papers. But in many cases, I would have decided to do a vitrectomy much earlier than these. In these cases here, I wouldn't wait so long. I start much earlier. And the first hemorrhage, the first vitreous hemorrhage in a young diabetic eye, which doesn't clear up within, let's say, 2-3 weeks, I do a vitrectomy. Yeah. Very quickly, even if they are 40, 45, because you're running behind the disease. As the longer you wait, the more difficult it becomes. You do an intense laser treatment from inside, much easier than to wait, do a little bit laser, nothing goes on, then the bleeding is denser, then it's going down, then you don't see any effect on the inferior retina, so I do it very quickly and vitrectomy. But it's not included here. Vitrectomy is just it's a side effect of vitrectomy. So you see, that's what I wanted to say. Sorry, that this number here is really high after 5 years, and you have to imagine that the patients need a lot of time to come to all examinations and to all controls and follow-ups and visits. That could be critical after some years, because in the first and the second year they say, oh, that's good, but it's becoming annoying in the third, fourth, and fifth year, because if these people are busy and professionals, they don't have so much time and don't want to spend so much time to get an injection maybe every month here after 5 years. That is pretty high. So here it is. What I found interesting, that this difference in the visual field defect after 2 years, it's not present here. It decreases, this difference decreases. This is probably because we don't do these laser treatments like it's shown here. This is a comparison of pattern laser and let's say scattered intense laser treatment without the scatter. You see that this is an intense burn, much more than here. And we do this one here, so we don't need to make white burns. Light gray burns are sufficient. Yeah, because they're becoming bigger, and that's the reason why the visual field is lost. It's more or less one scar all around the retina. So after 5 years, adverse events, hemorrhages. So the anti-VEGF group is increasing. We had much more in this laser group, now we have the same. And the vitrectomies are going up. The number of vitrectomies is, let's say, 1/5, 10%, 20%, even higher in the laser group. That's what I told you at the beginning, that the effect is decreasing over the years. And here is a very interesting chart. Injections required in the first phases. Everyone gets an injection. So you see a very rapid improvement. The neovascularization status decreases very quickly. Yeah. Oops, they are gone, resolved here. This category gray is resolved very quickly. There are just some failures here, very minimal. This one is increasing, but the longer we go, you see this effect, which is increasing so rapidly at the beginning, remains stable and is going down afterwards. And the number of worsenings is becoming more and more and more. So this is a quick effect, but probably not the long-term effects which we wish. And that's the reason why many patients need so many injections over the time, which means a lot of time spending in the clinics, a lot of numbers of visits, of follow-ups, which could be critical for professionals and could be critical for those who need someone to reach a clinic, to be transported by someone, because we don't have trains and buses everywhere. In all the villages we have, most of the people need someone who brings them to the clinic. So there's someone who has to take one holiday to bring them and take them home again. So this is, when you see the dropout here, at the beginning, more than about 200 participants in both groups, but after 5 years, there are just 6 of 10 left. So 4 are missing in this period. And this bigger group, the bigger the group is, the more you lose. And this has an effect. Because we know that laser works over years and years, but anti-VEGFs do not work over years. They might work quickly, but it's not clear if you stop what happens afterwards. And in spite of these monthly injections, you do not treat, let's say, the ischemia of the retina. You treat the neovascular vascular vessels, not the ischemia. So probably this is a big problem, because when you interrupt the treatment, you go back to the start. 85% start with monthly injections again. So this is probably not the perfect long-term therapy, because the point is, as soon as you lose these patients, they will be pushed back or even more, because when you look here, when you have no treatment for 6 months, yeah, you find a high number of traction retinal detachments here and a high number of rubeosis in comparison to this laser group here. So the visual acuity significantly drops in this VEGF group, but it does not drop in the laser group. This is stable. And this is significantly different here. 10% versus 1% and 4 versus 0%. Making an interruption for 6 months or longer might be a disaster for the anti-VEGF therapy group. Yeah? And they end up, a lot of them get in bleeding, intravitreal bleeding, get in rubeosis, get in traction retinal detachment, and half of them has a hand motion as a final visual acuity. So this is really a dramatic decrease and a dramatic ending in interrupting anti-VEGF therapy, and that's the reason why it's so critical to do it, or to decide for it. Yeah. And another potential complications might occur when you inject IVOMs and IVOMs and IVOMs. If you need a cataract surgery, you have a much more higher chance for posterior capsule rupture and an anterior vitrectomy compared to eyes which had no IVOM. And last but not least, it's a risk of endophthalmitis, especially in diabetics. When you imagine you inject for 5, 6, 7 years, let's say the likelihood to develop this hypopyon increases. So I wouldn't for me, I would not accept to get monthly or 3 injections a year. So the question is not what is better. The question is, what can I demand from my patient? As soon as you see there's someone not mobile, not willing to follow all these examinations, to follow all controls, then it makes no sense to start with anti-VEGF therapy, because this is just a bridging to do something else and end up in a laser treatment, because this is so annoying. They won't be adherent in the same way as they are adherent when you do laser treatments. And this, in spite of visual field and all these things, you can prohibit it when you do a soft laser treatment as well, or you go on with an vitreoretinal surgery, because let's say it ends with one surgery, one intervention, and not with 20, 40, or 30 interventions like here. This had to be seen critically and decided from patient to patient.